Hey everyone, this is Shane Sloan with Nursing CE Central. Today we're going to be talking about coagulopathies. So this course is going to cover DSC, ITP, and TTP. And I know that's a lot of acronyms, and we're going to go over all of those. So just want to give a brief introduction on myself. As many of you know, I'm the owner and administrator of Nursing CE Central. I'm also a practicing acute care nurse practitioner. Been working in critical care for about 6 to 8 years, so I have significant experience dealing with these issues. So I hope you guys enjoy this PowerPoint. It is geared a little more towards APRNs, however, it's very appropriate for RNs as well. I think if you're an RN taking this course, you're going to really enjoy it. You're going to really step away with a lot of additional knowledge. So yeah, and this is the first of our animated or dictated lectures. So these are via PowerPoint. These are for nurses who want a little bit more of an immersive experience than the read-through slides. So it's a little bit higher quality. So let's jump right in, guys. So the first one we're going to talk about is disseminated intravascular coagulation, DSC. Many of you have seen this before. So essentially, guys, what we have to think is what's going on here. So what is happening actually is two things. So they're clotting intravascularly. So the small and medium-sized blood vessels of the body are filling up with clots, and so that's obviously bad. The other thing that happens is they actually deplete all of their clotting factors because of this, and then they start bleeding from other places. So you have clotting intravascularly, and at the same time they're bleeding everywhere else. So it's characterized by widespread, uncontrolled fibrin formation intravascularly. So that's a very important thing to remember, guys, is that fibrin formation is what's the initiating factor of the clots in DSC, and that's going to be important to remember later. It can affect a lot of sites. It can affect the lungs, kidney, liver, brain. They can all suffer ischemic injuries due to this, and in some cases it can actually cause thrombosis and sometimes embolism. So these patients, you may see signs of decreased perfusion, and that may be because they're in a shock state, one, but two, they're getting less blood flow to their organs because they have a lot of clots. And these are oftentimes very, very small clots, but they can be large. Another key thing to remember with DSC is that there's persistent and extreme consumption of clotting factors and platelets, and that's why they have systemic bleeding. So just keep that in mind. DSC fibrin is what the clots are made of, and they're using a lot of clotting factors. So common bleeding sites are old venipuncture sites. So a lot of times you'll see patients who are oozing from all of their sticks that they got down in the ER. Now they have 6 or 7 places where they're just oozing blood. GI hemorrhage is not uncommon. Pulmonary, so you can see hemoptysis, and in some cases CNS. So this can lead to brain bleeds. Anywhere in the body can actually bleed, but these are some of the more common sites. So one thing that should always make you think, is this a coagulopathy, and specifically DSC, is when you have bleeding from 3 unrelated sites within a short period of time. So your septic patient is admitted, and then all of a sudden you go in the room and they have a little blood coming out of their NG tube, and they have some blood in their Foley catheter, and they also have a couple of IV sites that are bleeding. So that should always trigger you to think coagulopathies, and specifically DSC if they have risk factors. So the next one is immune thrombocytopenic purpura, or immune-related thrombocytopenic purpura, also called ITP. This is the least acute disorder, but we're going to discuss this one because it is something you're going to see in your hospitalized patients. It's an acquired disorder that leads to immune-mediated platelet destruction. So it's an autoimmune disease in which the platelets are actually attacked. It's usually chronic, usually seen in adults, and it's often characterized by mucocutaneous bleeding and a really low platelet count. So very common finding is a patient comes in with easy bruising, or they have increased bruising, and you'll check a CBC, the platelet count is low, and the workup will lead you to a lot of things possibly. So you have to think malignancy, liver issues, spleen issues, but once those are ruled out, you need to start thinking about ITP. And this is kind of a nice graphic here. And you can just see that there are, reduced number of platelets with ITP, so that's pretty straightforward. So the next one we're going to talk about is thrombotic thrombocytopenic purpura, TTP. So this one is more rare. This one is the least common of all three, but the most deadly. So TTP is characterized by a deficiency or antibodies to the Adams T13 protein. So Adams T13 is a lab. You can check this. You can check the activity of this. The problem is it's a send out at most every hospital unless you work in a major academic center. So as we discuss the treatments, just remember this is not something you can check quickly. So oftentimes if you suspect TTP, you have to treat those patients. Just a heads up on that. So what Adams T13 does is it cleaves to von Willebrand factor. And so when there's not enough Adams T13, von Willebrand factor, as you can see here, von Willebrand factor, lets those platelets clump together. And so the platelets just clump together and cause clots and all kinds of issues. So usually you see an Adams T13 level of less than 10% with TTP, but it could be a little more than that. It varies, but that's a typical cutoff to start suspecting this. TTP, if left untreated, classically can lead to hemolytic uremic syndrome. There's a lot of debate about that in the current literature of whether they're actually two separate conditions. So we're going to leave hemolytic uremic syndrome out of this lecture because that's a whole nother lecture's worth. So remember how we talked about in DIC the clots are fibrin rich? Well, here they're platelet rich. So that's why I drew that contrast for you. So you can see here these are clumps of platelets with TTP. So that's important to remember when we discuss the treatment. So just a little overview. These three disorders are separate clinical syndromes, but they all lead to a couple of things: thrombocytopenia and bleeding. So we're going to discuss the history, the physical, the symptoms, the laboratory tests, and last, the treatment for all of these diseases in this PowerPoint. So first we're going to talk about a history, physical, and symptoms just generally, okay? So the first thing you want to consider is when a patient comes in with low platelet count, you have to always consider context. Context is everything, okay? Not every patient with a low platelet count has DIC, TTP, or ITP. As a matter of fact, most don't. So let's talk about some other common causes. So drugs and herbs. We all know that there are lots of drugs that can cause thrombocytopenia, right? So heparin, quinine, sulfonamides, to name a few. There's also several herbs. Ginseng has been implicated. So, when you're doing your history and physical, always let the patients tell you what happened. Always listen very carefully. Always ask questions about drugs and herbs. Have you started any new herbs lately? Any new drugs lately? Splenic sequestration. And this is, these patients are not going to be acutely ill, obviously. So the spleen, as you know, can sequester platelets. So if you have a patient that comes in with thrombocytopenia, it's very reasonable if you don't suspect something else, something more urgent. Check a left upper quadrant ultrasound. See if there is palpable splenomegaly, because that can often be a cause. Myelodysplasia and malignancy, they're listed separately here, but if you see these things, if you see things like pancytopenia, that's a little more indicative of myelodysplasia or malignancy. Now, malignancy and myelodysplasia can present with isolated thrombocytopenia, so always keep that on your mind. And last but not least, liver disease. This one's a little hard to distinguish from DIC because they have a lot in common, but obviously you have to use judgment here, right? What brought the patient in, what kind of risk factors do they have, is this an acute condition, and they can be concurrent, so patients with liver disease can develop DIC. So again, these are just some things to keep in mind as you're examining patients that come in with thrombocytopenia, and there are a lot of other causes, guys. These are just some of the more common ones. So as we go through this, we're going to have a case study that's going to kind of help us follow along and understand and put it all together, hopefully. So in this case study, we've got a 26-year-old male who presents with the ER with complaints of fever. On exam, he has altered mental status, tachycardia, and hypotension. You notice that he has diffuse purpura. Spleen and liver are non-palpable, and there's no stigmata of liver disease. So to get things started, we order some pan cultures and a head CT. Mother's at the bedside. What do we want to ask her specifically about the purpura? So there's a lot of things we'd want to ask her, obviously, but as it relates to the purpura, what do we want to ask her? So just a few questions we would want to ask. Does he have liver or spleen issues that are known? Is there any history of thrombocytopenia or clotting disorders? Any drug or herb use, especially anything recent? Any history of cancer? Any recent infections? And any bleeding, right? We want to know, did he throw up some blood yesterday morning? That could be very important to know. Has he been urinating blood? And then obviously a general HPI. So we want to know everything, right? This guy's young and he's sick. So let's talk about the history and physical and symptomology of DSC. So the incidence, about 1% of hospitalized patients will actually experience DSC. Now, this number has been argued a little in the past. A lot of this is clinically insignificant, right? Patient may have some very mild DSC with sepsis that we don't really ever need to do anything for. Patients with fulminant DSC is less common, but you will see it if you work in the hospital, and especially intensive care, for enough time. So there's two types. There's acute and chronic. We're not going to talk about chronic because it's not life-threatening typically, and it's a whole different treatment, right? So some of the common causes, and there are a lot of causes, again, these are just some common causes. Bacterial sepsis, number one by and large. Transfusion reactions, so patients who receive blood that wasn't fully compatible in any way are at risk for DSC. Snake bites is a big one. If you guys are in an area of the country that you've seen some rattlesnake bites or some water moccasin bites, any kind of pit viper really can cause DSC, and I've personally seen this several times here in Kentucky. Malignant disorders, obstetric causes, so about half of the women with abruptio placenta and amniotic fluid embolism experience DSC. Again, maybe not clinically relevant levels, but they definitely do experience it, so you always have to be on the lookout for that. So some things you can see is you can see ischemic changes and damage to the lungs, kidney, liver, brain, any other organ. So when your patients have DSC, guys, it's just very important to always consider clots. So if you have a patient with DSC, maybe they don't have any other risk factors, maybe they're even young, and you go in and there's a neurologic change, you have to consider that this patient, had an ischemic stroke. At least consider those kind of things more than you would in a 26-year-old who didn't have DSC, right? Often they're hemodynamically unstable. Shock is common. Again, it often manifests as unrelated bleeding from 3 sites, and they're clinically sick typically, right? These people are not well, they're pretty sick. So ITP, the incidence is about 2 out of 100,000 adults per year. And ITP is often secondary or triggered by another disease, lupus, HIV, hepatitis C, and there's some connection with Helicobacter pylori as well. These patients, again, are often asymptomatic. They present with ecchymosis or some petechiae, some new bruising. Common in females is new reports of heavy menstrual bleeding. So always be on the lookout for that. If females, come in and report heavy menstrual bleeding, that's new, that's out of the blue. Always check clotting factors and platelets, to consider these kind of things. Folks can develop ITP after an acute infection. And the one big thing you need to know about ITP is if they come in with wet purpura, that's the name, wet purpura. So that means they have blood blisters in their mouth. And if you've ever seen these, they're pretty bad looking. They're these big, kind of wet, actually. They look wet with blood because they're kind of seeping with blood, blisters in their mouth. These have classically been thought as a heralding sign to massive bleeding. So folks with ITP can have massive bleeding. So if you see wet purpura, you always need to check a platelet count, and you don't let the patients go home like that, right? You have to check the platelet count. You have to follow up on that. They're not usually clinically sick. These people are typically more chronic unless they're having an episode of massive bleeding. And then we have the most feared coagulopathy, and that's TTP. So it's pretty rare, right? So 0.4 cases per 100,000 adults per year. I personally have only seen this once after treating thousands, tens of thousands, of patients in the ICU over the years. So this is kind of a lot, and I understand that. So I hope this doesn't offend anyone. I'm just putting this out there because it's classic teaching, but there's a good acronym that helps you remember TTP, and that acronym is FATRN, F-A-T-R-N. So fever, anemia, thrombocytopenia, renal damage, and neurologic changes. When you see that constellation of symptoms, you have to always consider TTP, okay? So just remember that, and that's all just listed out up here, but this is a lot easier to remember here, this acronym. Any or all of them may be present based on the severity of the disease. Classically, it's taught that the renal failure is pretty bad. They often have dark urine because hemoglobinuria, pallor and jaundice often present due to the lysing of red cells, and that can be present in a lot of coagulopathies, not necessarily specific to TTP. Malignant hypertension, just as a note, can present similarly. So I'm sure all of you guys have seen that patient that comes in with a systolic of 240 or 50, and it can cause all these same things, right? So it can cause, minus the fever, right? But it can cause anemia, thrombocytopenia, renal damage, and neurologic changes just due to the pressure that's within the vessel walls in a quick period of time. There is some evidence to say this can be related to certain drugs, so clopidogrel, gemcitabine, all those things can be related, but that's a little bit controversial. But if a patient started one of those drugs, maybe you should think about TTP a little more. And usually these people are very, very sick clinically, but they're not usually hemorrhaging severely like you see in DIC, but they're very, very sick. Okay, so we're going to move back to the case study. So your patient's CT of the head was negative, and blood cultures were positive for gram-negative rods. So we're going to say this patient has septic shock, right? Broad-spectrum antibiotics, fluid resuscitation, and a sepsis protocol are initiated. The nurse notifies you that the patient has begun oozing from his IV sticks, and Foley catheter is now emptying bright red urine. Which diagnosis do you think is most likely here? I'll give you just a second to think about that. Is it DIC, is it ITP, or TTP? Okay, so DIC is most likely just because the patient has fulminant sepsis, right? We know that's a risk factor, and we know DIC is a lot more common, right? So you would tentatively say this patient has DIC. TTP can't be ruled out, though. He does have fever, altered mental status, likely has renal issues with the shock, so you can't rule it out, but it's not very, very likely at this point. And ITP is very unlikely. It's not usually severe and acute like this. So next we're going to talk about the laboratory data. This is really going to help you diagnose and differentiate between these diseases. So some of the initial workup, you'll obviously want to do a complete blood count, coagulation tests, so PTT, PTINR, all those things. Peripheral smear. A lot of people are not familiar with a peripheral smear. So essentially in a peripheral smear, it actually will be the pathologist or someone similar who's going to get a specimen of the blood and examine the blood very closely for any irregular cells. And when you order these, you're going to see a lot of irregular cells. You're going to see, they're going to have a report that's going to come out with 10 or 15 different irregularities that are possible based on what your institution has set up. But what you're looking for here is schistocytes. So that's schistocytes. Okay, so schistocytes are fragmented red blood cells. That's all there is to it. It's not any more complicated than that. When you have a condition that has clotting like this, so what happens is as the body is having these clots like we talked about in DIC and TTP, specifically, blood is going to be turbulent as it flows through those areas that are clotted. And so what happens is the red blood cells are lyse, and so then what you see is schistocytes. So schistocytes are nothing more than lyse red blood cells. You're obviously going to check a D-dimer. Haptoglobin is another test people are not super familiar with, and that's okay. Depending on the size of your institution, it may be a send out. It's not critical to your diagnosis, but it's certainly helpful. Haptoglobin is decreased when you have DSC and TTP. You want to check an LDH and an indirect bilirubin. Your indirect bilirubin is obviously going to be elevated because of the lysis of the red blood cells, right? Some other things, you should probably check liver function tests and abdominal ultrasound, just to be concise. Anything else that you want to specifically check, obviously, but this is just relating to the coagulopathy. And there's not one single test, guys, that's going to tell you this is X condition, maybe with the exception of the Adams T13 levels with TTP. So these are the normal values. I'm not going to spend a lot of time here. Everybody knows normal platelets, normal PTT, normal INR, normal D-dimer, normal fibrinogen, FDP, fibrin degradation products. This is really quite uncommon to have available, so I wouldn't worry about that too much. Haptoglobin, that's going to depend on your institution. That's obvious. A lot of times it's in nanograms per deciliter, so just be careful with that one. Just look at whatever your lab's reference is. LDH, indirect bilirubin, and on a normal peripheral smear, there are no schistocytes. So first we're going to talk about DSC. So what is specifically different about DSC? So you're going to see thrombocytopenia, and it's a rapidly decreasing platelet count. So we're talking, you may check it 1 hour and it's 75,000, and check it again in 2 hours and it's 40 or 50 or 30,000. You're going to have an increased PTT and PT. So that's really important here, because in TTP, you don't typically have increased clotting times. That's one thing that can help you clue in on one or the other, okay? So remember, in DSC, low platelets, high clotting times. You're going to have schistocytes because there's red blood cells being lysed, right? D-dimer might not be initially elevated, but it'll be elevated for certain. And varying levels of anemia, so these patients are going to be anemic to some degree. But if you have a young, healthy person that comes in with a hemoglobin of 15, they may only be at 11 or 12 by the time you check it. So just remember that they've still lost, a fourth of their red blood cells. That's still going to be really, really impactful on that person. Fibrin degradation product, like we talked about, it's a little more probably sensitive and specific than D-dimer and fibrin levels, but it's typically difficult to check. Fibrinogen might be normal or decreased, so the more they bleed, the more fibrinogen they're going to use, and it's going to eventually be decreased. Haptoglobin is going to be decreased. So I know that's a lot to take in. I would recommend looking over this slide a few times, but the takeaway is low platelets, high clotting times, and haptoglobin is decreased, and you have schistocytes on your peripheral smear. That's really very, very indicative, especially with a risk factor, snake bite, sepsis, something like that, of DSC, and then obviously the bleeding from 3 unrelated sites. So ITP, this one, it's a little more straightforward, so that's good, right? They have decreased platelets. Sometimes you see large platelets on the peripheral smear, not always. They're going to typically have normal PT, normal clotting times. And sometimes they have an iron deficiency anemia, just because this is a little more chronic. A lot of times they have a very slow GI bleed. Those things are not uncommon. So you also want to look for underlying causes, right? So lupus, HIV, hepatitis, H. pylori. So for this is a little more of, you can take your time to work up typically type thing. What you're usually going to check is immunoglobulin levels, IgA levels, monoclonal gammagopathies. But these things, you're typically just going to consult hematology here. Unless you're a hematology nurse or nurse practitioner, you're probably not going to be working up a ton of ITP, because there's really no need to acutely typically, right? And interpreting these things is more of a specialist level thing. So next we're going to talk about TTP. So again, on the initial labs with TTP, you're going to see thrombocytopenia, renal insufficiency or failure. Now, a key difference here between DSC is you have normal PT and PTT, specifically the PT. So that's really important. So when you check those clotting times, if it comes back and it's elevated, you're thinking this may be DIC. If it comes back and it's normal, you really should consider TTP a little more. You know, it's a lot of factors, right? But this is one that tips the scale in favor of TTP, and a lot of experts advocate using the clotting times as a you know, all other things being equal, assuming that we have all the other symptoms, using that as a good indicator that this might be TTP. So a lot of times you have a normal D-dimer. Again, you're going to have schistocytes because we've got clots, right? So there's going to be clots causing turbulent blood flow. LDH is often increased. Indirect bilirubin will be increased. Haptoglobin, again, is going to be decreased. And here's another one, guys, like we've been talking about, the Adams T13 level. Again, it's not usually available. You're not going to have the luxury of checking this and then initiating treatment based upon it, but you need to check it. You need to send this out so that you can get an answer for this patient and family, but you're going to have to carry on and make a treatment plan without it, right? So the thing that I'm going to emphasize here, and we're going to talk about it in a moment, is the mortality with TTP is about 90% left untreated. And the treatment for TTP is very different than DIC. So it's really important that you know the difference between these conditions, especially if you're practicing in critical care, and initiate treatment, you know, based on that. And again, if you're ever in doubt here, hematology, if they're available, is a great resource. But the thing is, you can't consult hematology for every patient with a thrombocytopenia. And if you consulted hematology for every patient in the ICU with a thrombocytopenia, you'd probably need a full-time hematologist. So you're going to have to be able to some degree, work through this on your own and come up to a conclusion of whether this is possibly TTP or whether this is likely just DIC or something else that's typically treated by the primary team. So critical care hospitalists treat DIC all the time. It's not complicated. You should not be treating TTP on your own ever. This is always a hematology consult. So that was a little bit off topic, but I just want to emphasize how deadly TTP is. So the consensus among experts is that if you think that it's TTP, if your labs are indicative of TTP, and you feel strongly that it's TTP, you need to treat this patient accordingly. Just another small note, there's an increased incidence of TTP in patients with HIV, so we know when the smoke clears, do check them for HIV. So we're going to move back to the case study again. So your patient's now admitted to the ICU and is more stable after fluid and blood resuscitation. The oozing and hematuria continue. Patient's blood work reveals severe thrombocytopenia, schistocytes, so we've got lysing of red blood cells, elevated clotting times. So what else might we order at this point, right? So just based on this, though, this all again speaks to DIC, right? Because of mostly what helps us differentiate this from TTP, again, is that this patient has elevated clotting times and they have a risk factor for DIC, the sepsis. So you'd want to check a D-dimer, an FDP, and a fibrinogen. Those would be the next test to check. And those are not absolutely critical. None of these are probably going to change your treatment, besides maybe the fibrinogen. If it's critically low, replacing that, there's some evidence that may help. But the big thing in DIC, as we're going to discuss, is supportive care. So let's talk about treatment overall. Let's talk about what you do and don't do with all of the patients with the coagulopathy, right? So you always limit invasive procedures to what's absolutely necessary. So IV sticks, NGOG, rectal temperature, shaving, IM injections, right? So if you have a patient with TTP, this is not the patient that you want a new nurse practicing an IV on, right? This is not the patient that you want to do rectal temperatures on if you can help it, right? This is not the patient that you want to give IM Ativan to, right? So just limit those things as much as possible. Again, on the procedures note, if you have to do a procedure, right? So these patients are sick. They need things, right? They need intubated, they need central lines, they need dialysis catheters. If you have to do them, which is very common, if you work in critical care, you know that you can't always get around it. What you do is you optimize their platelets and their clotting factors and fibrinogen immediately prior to performing the procedure. So let's say you need to put a central line in, right? So you get the patient's platelets up, ideally above 100,000, but that can be an uphill battle sometimes. So, and you want to get their clotting times to something reasonable, right? So it's very common that people will like to have platelets infusing during a procedure. I don't think there's any evidence for that. I also prefer that because anecdotally it seems to help things quite a bit. But definitely get some in before, plus minus during, and optimize the clotting factors. We're going to talk a little more about that. Very obvious here, guys. Hold the anticoagulants. And I say obvious, but you would be surprised how often in our daily checklist of just going through our rounds, we say, oh, this patient doesn't have DVT prophylaxis. Let's start it. And we forget that they also have a diagnosis of DIC or TTP. You probably wouldn't forget TTP, but just make sure we're on the lookout for that. Hold direct pressure to any external bleeding site. So this is really going to be important that people understand how to actually hold pressure here. This is something I see a lot. So, you'll go in, you put the central line in the patient, you ask a nurse to hold pressure for 15 minutes. And so what you really want to emphasize here is holding pressure for 15 minutes doesn't mean 5 minutes and then let go and look. It doesn't mean 5 minutes and then get into a conversation and kind of let go a little bit. It really has to be direct pressure on the insertion site or on the site that's bleeding. It could be anywhere, right? Has to be direct pressure that's uninterrupted for 10 to 15 minutes, and that's really, really, really important. And unless you work in trauma, it's not something you have to do a whole lot, right? So it's kind of hard to appreciate that. But every time you let that pressure go, that site's going to start bleeding again, and you're starting over from ground zero. So just make sure that you, the nurse, whoever's doing it, hold the pressure for at least 10 to 15 minutes and don't let go. And you locate the sources of bleeding and treat them appropriately, right? So if they're having a GI bleed, then you want to consult GI and have a discussion about treatment for that. Obviously, retroperitoneal bleeds, anything's on the table here. So anywhere that can bleed has bled in a DIC patient, and so you have to always be cognizant of that. So the replacement guidelines are a little bit confusing, and to be quite honest with you, it's really based on clinical status of the patient, right? So I'm going to go over the specifics here, what's recommended, but again, I'm going to emphasize that it's based on the patient, okay? It's based on how the patient is doing. So for patients with TTP and ITP, if they're having an active bleed, typically get the platelets to 40 to 50,000. If there's no bleeding, especially with ITP, don't replace it until it's 5 to 10,000. So what studies have shown and what experts have said is that in TTP and ITP, you can do more harm than good just giving them platelets, right? So a couple of things. So in TTP, remember that the clots are platelet rich. So there's a theoretic risk of making more clots the more platelets you give them. So it's really a fine line of trying to balance how many platelets you want to give and the risk of bleeding versus the risk of additional clots. So these are guidelines, these are recommendations, but you have to really make a call, right? The one exception to that is with ITP, their platelets run low. So if you try to replace these patients up to 150,000, they would live in the hospital. So most guidelines say replace it when it's below 5 to 10,000. Always remember, and this is not specific to this, but women of childbearing age need Rh negative platelets in general. And if the patient's been on aspirin, again, this is not specific to these, but if they've been on aspirin, remember that aspirin inhibits platelets. The time frame is slipping me. I'm thinking, 4 to 5 days, or maybe it's the lifetime of platelets. It really doesn't matter. If they've been on aspirin therapy or any antiplatelet therapy, their platelets are essentially not working. So you have to consider that. So you may have patients who come in who are bleeding and their platelets are not that low, but you still may need to replace them because the platelets they have may be inhibited by a drug like aspirin. So in DIC, a little more aggressive here. So experts say you want to keep platelets between 50 and 100. Just a note here, in general, every unit of fresh frozen plasma that you give will reduce the coagulation times by about 30%. You want to keep the INR less than 2, but I'm going to emphasize here that if you have a patient who you've transfused up to 40,000 platelets and their INR is 2.4 and there's no bleeding, sometimes it's best to leave that alone rather than pumping them absolutely full of products, trying to reach an arbitrary number. Fibrinogen, most folks say if it's less than 100 or if it's going down really, really fast, you need to replace it. Some people cite a 5-to-1 ratio of FFP to fibrinogen, and this is really becoming more popular in the literature in general, is that we have to really keep the balance of products in the body right. So you don't want to give patients 10 units of FFP and no fibrinogen, right, because they work together. So just remember, if you're replacing a lot of fibrinogen, or if you're replacing a lot of FFP, you probably want to give some fibrinogen with it at a 5-to-1 ratio. So case study again, the patient's now in septic shock, requiring vasopressors, large volumes of fluid and blood. Nurses are unable to obtain peripheral access. Your team determines that a central line is necessary. What do we do before the central line? So I'll give you guys just a second. I know we've talked about this. And so remember, the patient has low platelets, they have prolonged clotting times. So we want to check all the values and replace them immediately before we insert the line. And we discussed that earlier. So the other thing to remember here, guys, is these are not the patients for people to be practicing their central line skills on. It's not the patient for the resident to practice on. The most experienced person needs to be putting these lines in, because if you cause trauma, I mean, I'm sure many of you have seen this before, but they can bleed and bleed and bleed like you wouldn't believe. So let's talk about the treatment. This is really the meat of it, right? And it's not that exciting, actually. So DIC, the mortality is 30 to 80%, and it really depends on what caused it, right? And the treatment for DIC is very simple. You have to treat the underlying cause. If the underlying cause is sepsis, you have to treat the sepsis. If the underlying cause is an obstetric emergency, you have to treat said obstetric emergency. It's not going to resolve without treating those, because it's really a sequela of that. Always, airways and hemodynamics are important to control, as well as bleeding. So here's a little note, guys. It says thrombus and embolus may develop during DIC. Risk of anticoagulation with heparin should be weighed. So you're going to see a lot of range of patients with DIC, and you're going to see patients who come in with a platelet count of 10,000. You're going to see patients with a platelet count of 80,000. You're going to see patients who've had 5 ischemic strokes and patients who have no risk factors. So some institutions, some folks do anticoagulate patients who have less bleeding risk factors and more clotting risk factors. So, if the patient comes in and they're on, Coumadin at home and aspirin because they've had 3 heart attacks and 4 strokes, and they're not really having any bleeding, it's a very mild case of DIC, that may be a patient you might anticoagulate. I mean, you would have to see the clinical picture. You have a patient who comes in and they're bleeding from everywhere and you just can't control it, obviously it's a very bad idea. But just want to throw that out there. And experimentally, heparin has been used as a treatment for DIC. There was some theoretic thought that because the heparin would break down some of the clots, it would disrupt the process. To my knowledge, none of that has become fruitful, but I know that some folks still hold on to that old dogma. So just want to throw that out there. So ITP, a little bit busy here, but let's just talk about it, okay? Usually doesn't require treatment. So if there's no active bleeding or significant risk factors, it can be deferred. Some patients have spontaneous remission of ITP, about 30%. Again, 5,000 is kind of our threshold of where we transfuse, even without bleeding. We said 5 to 10 earlier, so 5,000 would be the absolute. Again, if you have wet purpura or retinal hemorrhage is also an emergency, okay? So retinal hemorrhage or wet purpura, really need to consider giving those patients some platelets and admitting them, because that can herald a life-threatening bleed. So again, this is more of a specialist treatment here, but I just want to go over some of it. So prednisone is one therapy. Obviously, it's an immune-mediated disease, so prednisone. Some people have used IVIG. I shouldn't say some people have used. That is a therapy for ITP, but it's typically reserved for severe refractory cases. And there's some other other things that hematologists can pull out of their bag of tricks, like rituximab. And then splenectomy is actually a treatment for ITP, but it's typically offered last because it obviously carries its own risks, cutting a patient doing major surgery on a patient who has a clotting disorder, right? So, but know that it is an option because it does put more platelets back into circulation. So TTP, this is the one we're going to really hone in on in treatment, okay, guys? So again, 85 to 100% mortality if it's not treated, 10 to 30% with treatment. So you're not out of the woods once you recognize and begin treatment. So if you suspect TTP, you need to get a stat hematology consult, okay? Next thing you need to do is you need to transfuse them. So what you do is you transfuse 2 units of fresh frozen plasma. That's classic treatment before you can get other things initiated. Especially if you're at a smaller hospital, it's going to take some time. And again, always talk to hematology, see what they want. But that's pretty typical, is to give fresh frozen plasma in the interim. So the definitive treatment, and this is important to know because this is what they're likely to die without, is plasma exchange. That's what you're going to do, is a plasma exchange. And I know a lot of folks have seen this for other conditions, but it's the mainstay of treatment in TTP. And so, there's no hard and fast rule, but typically you continue this until the platelet count is normal and the hemolysis is resolved for at least 2 days, and renal function and neurologic deficits have resolved. So typically 15 days is the treatment. I will tell you that TTP is one of those things that even hematologists have typically seen rarely, even hematologists at major academic medical centers. So the thing that I really need to emphasize here is the treatment is not standard, right? So we say plasma exchange. Well, I've talked with several hematologists who've treated this. Some people say plasma exchange once a day. Some people say at least twice a day. It's not really well established. I think most people would say once a day, but just know that the more extremist a patient is in, the more plasma exchange and the more frequent they may need it, and it's really a case-by-case basis. And again, the 15 days, we say 15 days, it could be 7, it could be 20. Again, we've already talked about this, but platelet transfusions have a theoretic risk of causing clots because the clots are platelet rich. And the relapse rate is about 12 to 45% within the first 30 days. So really important that if a patient experiences TTP, this is not someone you just discharge home with an appointment to see their primary care doc in a month or even any time, really. They need to follow up with hematology quickly and be followed closely. And again, Adams T13, if they're deficient in that, the more deficient they are in Adams T13, the more likely they are to have relapse. So back to the case study. It's now ICU day 3, and the patient is responding to antibiotics. Vasopressor requirements are decreasing and renal function is normalizing. The oozing and hematuria have continued. The patient's required significant blood products. The mother is concerned about the bleeding and asks you what you're going to do to treat it. So what do you tell her? You tell her that it's secondary to the sepsis. The sepsis is getting better, and as the sepsis resolves, the DIC is expected to resolve and will continue to support the patient. So this can be hard for patients and families to really swallow, as they're bleeding from everywhere, and what are you doing besides giving them products? Well, the treatment is to treat the underlying cause. Okay. So we got a few review questions here, guys. So these are going to help you just kind of jog your memory. And if this is your first time watching this PowerPoint, I'd recommend taking a moment's break to kind of look over things before you move on to these, because this is a very complicated topic and there's a lot of numbers, a lot of acronyms, but I'm going to move right through these for those of you that are ready. So the first one is we've got a 65-year-old female who presents with complaints of general malaise and gum bleeding after brushing her teeth that's last 3 months. On physical exam, she's noted to have diffuse purpura, otherwise unremarkable. She denies falls or trauma. We do a CBC, platelet counts are 35,000. She has mild anemia. Which coagulopathy do you think she's experiencing? So I think pretty quickly we can rule out the 2 acute ones, right? So we can rule out DIC, right, because she doesn't have any risk factors. She's not clinically sick. Unlikely to be DIC is what I would say. We can pretty much rule out TTP because she doesn't have any of the FATRN acronym symptoms, right? So fever, anemia, thrombocytopenia, renal issues, and neurologic. None of those, right? And she's only bleeding from one side, so So the most likely thing here is ITP or another cause, malignancy, liver disease, et cetera, et cetera. The two big things is, this is probably not something acute. This is probably something more chronic in nature. Okay, so this one's a little heavy again. Just trying to reinforce what we've learned here. So we've got a 28-year-old female who's HIV positive. She presents with fever, altered mental status, pitting edema, and labs suggestive of an acute kidney injury. So we do labs and we find that she has a platelet count of 26,000. She has positive schistocytes, so we know she has red blood cells that are being sheared. Negative pan cultures, so she's not bacteremic. Normal clotting time, so PTI and RPTT are all good. Negative D-dimer and FDP, and she has a decreased haptoglobin and LDH. So which diagnosis do you think, and what's your next step, okay? So this is obviously a sick young lady, so we know this is something more acute, so we can pretty much, ITP, pretty unlikely here, okay? So then we're kind of left with, is this DIC or TTP? Obviously there are other coagulopathies, but for the purposes of this PowerPoint. So is it DIC? Do we really have any underlying cause? Not necessarily. Clotting times are normal, which in DIC they're typically elevated. So I would be worried about TTP in this young lady, okay? She has a lot of the FATRN symptoms we just talked about. She has HIV. She's got a lot of risk factors for it, and the presentation would fit classic TTP presentation, right? So what do? Do we transfuse some platelets and continue to monitor? Well, that's a pretty bad idea, right? We talked about platelets are not the best therapy. So what we want to do is continue the workup and treatment for possible TTP. So that would be giving her fresh frozen plasma and consult hematology. That's what we would do for this patient. Next one is a 56-year-old female presents with a history of ITP. She's on chronic prednisone therapy and presents to the hospital ER with oral thrush. On examination, she's noted to have retinal hemorrhages and several large blood blisters, so the wet blisters we talked about. So this patient's had ITP for a while. She's not worried about the findings. She wants to be discharged and see her hematologist next week. So what do you tell this patient? So we've already said that retinal hemorrhages and wet blisters, these large blood blisters, are heralding signs of very low platelets and a massive bleed. So probably not gonna let her be discharged, right? So let's say that D is not a good answer. We're not gonna say we'll figure it out next week, right? C is essentially the same answer. See your hematologist next week. So that leaves us with A and B. So A is your physical exam reveals that your platelet count may be extremely low. We need to check your platelets and possibly admit you. Seems very reasonable to me. B, your platelet exam indicates that you're about to have a life-threatening bleed. You need to be admitted. Well, it indicates that she is at high risk for one, not that she's about to have one. So A is the answer here, guys. Check the platelet count, admit the patient if need be, but be reasonable about it. So you're not going to let her go see your hematologist next week, and you're also not just going to admit her straight to the ICU. Next question, a 23-year-old female in your unit has been diagnosed with ITP. She begins having GI bleeding requiring 2 units of packed red blood cells. On the next CBC, her platelet count is 12,000. She continues to have hematoemesis, so she's having an active bleed. So what's your next step here? There's 2 things to consider. What do we want to get her platelets to, and does it matter if she gets Rh positive platelets? So this one's a pretty straightforward question. She's a young childbearing age female. She needs Rh negative platelets, unless we have confirmed she's Rh positive, but that's, it's best just to give these folks Rh negative because they go in and out so much, and it's very easy for an error to occur. And so what's the goal here? So we talked about it before. We want to transfuse Rh negative platelets to 40 to 50,000 because she's having an active bleed. Okay, guys, that's it. That's the lecture. I hope you enjoyed that. We'll be having more of these dictated PowerPoints. Would love to hear some of your feedback on this. So this PowerPoint was done in a format such that I went through the PowerPoint and at my pace, and it's one large video is what you're going to see. We could also break this down slide per slide. We're really interested to see what our viewers think about this. If you are completing this on the website and you're wanting to get continuing education credit for this to get your certificate, just click the complete button below after you've read and learned all this material, and you'll be redirected to your certificate. Again, I hope you guys enjoyed this. I hope you took away some good, valuable knowledge. I'm going to let you see the last page of the references as well. And okay, I'll sign off.